with my work, I feel the same way where I am now. And I work with traumatized individuals exclusively, and they all come with their own challenges for me in terms of how to communicate, how to connect with them. But I'm not drained. Some days are harder than others, but it is so meaningful. And I think a key to that too is when you understand where they're coming from. And I've said this before at some of the trainings, I want to shift how we see people and move from the fact that we think they're problematic to symptomatic.
Hello, everyone. I'm Angela Rosa DiDonato.
And I'm Marian Leary.
And you're listening to Amplify Nursing, a Penn nursing podcast supported by the Panola Fund for Innovation in Nursing.
Amplify Nursing features nurses who are leading the way in science, policy, and innovation.
Our guests defy stereotypes, define practice, and disrupt convention.
We highlight the breadth and depth of nursing influence on society by amplifying nurses who are pushing boundaries and breaking down barriers to build a new paradigm. Today on Amplify Nursing, we speak with Dr. Tracey Vogel. Dr. Vogel is an obstetric anesthesiologist based in Western Pennsylvania. Her interest in birth trauma and training as a sexual assault counselor led her to her current position as director of Allegheny Health Network's Perinatal Trauma-Informed Care Clinic, one of the first in the nation. This unique service offers comprehensive trauma-informed care for all birthing persons with histories of previous trauma, including shared decision-making in birth planning, multidisciplinary collaboration and communication, while also building patient trust and advocating for optimal outcomes for birthing parents and babies. Today, we discuss the importance of utilizing trauma-informed care in practice.
So, hi, Tracey. Thank you so much for speaking with us today.
Good morning, Angela. It's really a privilege always to have an opportunity to share my work and talk about this amazing group of individuals that I work with.
Yeah, that's awesome. We're really excited to have you. So, why don't we talk a little bit about you? How did you get into medicine?
Oh, that's a good question. I didn't start off wanting to go into medicine. I always wanted to be a teacher, actually. And we joke about that all the time because my parents said that they wanted me to be a doctor and I wanted to be a teacher. But I am now both, and I love it. And I don't regret it at all ending up in medicine. I've always enjoyed maybe the more personal interactions with the individuals, which makes me question why I went into anesthesiology to start with. But again, I have no regrets. I really enjoyed that profession too. But it has also given me skills and led me into the path that I'm on now.
I'm just really curious. So, how did you make that shift in medicine to teaching?
It's not really a shift. I always taught while practicing medicine, and I've always been on that type of track, as we call it, more of an academic track, an educational track. And I just find that the most rewarding part, I think, of my work, not just the individual care to patients, but training nurses, residents, medical students, other colleagues. I just always enjoyed that.
Yeah. So, why don't we talk about what you're doing now?
Which is a huge pivot, I'd say, from where I started. So let me just back up to give you some background on kind of how I got here. So I did my residency at Stanford in anesthesiology. Then I pursued an extra year of subspecialty work in a fellowship in obstetric anesthesiology, which I've always loved that area of medicine. In fact, I almost went into obstetrics and gynecology. So this was my way of getting into it. So I did those years at Stanford and then stayed on for several more as an assistant professor there, working a lot more in obstetrics, but still doing a little bit of everything. When I moved back to Pittsburgh, I still did a little bit of everything. 50% obstetrics, anesthesia, and then the other 50 was generalized. But then ultimately, after about 10, 11 more years in that practice, I realized I just wanted to focus on obstetric care. And I found a job that allowed me to do that. And that really was the big change for me, is being able to work exclusively with obstetric patients every day, I started to see things a little differently. I could follow with patients. There was more continuity of care. So in that realm, I started to see and recognize some, maybe I'd call them disturbing trends, things I didn't quite understand. And I wanted to explore that a little bit more. There were things going on in my personal life where my kids were reading books about rape crisis in their high school classes, like Missoula by John Krakauer, 13 Reasons Why was on television. So I watched that with my middle school child. And I had a patient that was referred to me that had PTSD, and I didn't understand that. So all of those things were happening. And it led me to volunteer at our local rape crisis center. I thought I was going to go and volunteer once a month or something like that. Instead, I ended up becoming a sexual assault counselor, doing the full training. And that is my first exposure into a certain kind of trauma, but what trauma survivors look like, what do they need? And now I had context for some of what I was seeing in obstetrics. So that was a really big pivotal change for me. So then I wanted to try to make sense of what I was seeing and do something about it. So raising awareness and then action after that. And I ended up receiving a grant at the beginning of COVID to create an infrastructure for a clinic. And I created a perinatal trauma-informed care clinic during that time as an extension of a high-risk obstetric anesthesia clinic that I already was running. It was kind of a natural extension. And that's what led me to have this full-on 2.5-day-a-week clinic. And then the rest of my time I spend mostly training and teaching other folks in trauma-informed care in the obstetric space. So that's kind of a summary of how I got here.
Let's talk a little bit about how prevalent this is, because that was one of the things that struck me. I attended your workshop, which is what brought us here, because I felt like it was so important to share with everyone, as many people as we could possibly share this with, because it is so incredibly important. But it really struck me how prevalent this is when we were in our small groups talking about the patients that we all have seen. And I think it's so much more prevalent probably than even anyone could possibly imagine.
Yes, I agree with you. I think we're not capturing all of these episodes of traumatic birth experiences because we're not asking the right questions yet.
Mm-hmm.
But if we look at some of the data and the studies that are out there, up to roughly 44% of women might report their births as being traumatic, which really suggests that not always joyous in the land of obstetrics. And it certainly doesn't fit with what a lot of individuals are seeing on social media, where they think birth is beautiful, perfect, it's everything they want it to be, which for some women it is. But when we think about a number like 44%, that's high. Yeah. And in certain populations, we know for sure that it's going to be high. For example, if there's a perinatal loss, I don't think anyone would question that that is a very traumatic event for people. But there are things that providers, I don't think, even think about as being traumatic to another individual. We tend to focus on those concrete, tangible diagnoses that we can take off the chart. For example, we know that severe hemorrhage can increase the risk for postpartum mental health issues, including PTSD. That's an easy one. You can pull that out of the chart if you wanted to look for it. We know that someone going to the ICU for a critical event could increase the risk. We also know that someone who has significant pain during cesarean delivery or has severe post-dural puncture headache from an epidural, for example, can go on to have those significant events and have trauma. But what we're not picking up is those feelings of helplessness or powerlessness, loss of control, terror, negative interactions with caregivers, or a negative subjective experience of childbirth. those are bigger predictors of postpartum PTSD and mental health. And that's not always apparent to us as providers. I don't even think we're taught to look for those things. And that's why I think we're just scraping the surface right now.
I noticed, I also do a lot of OBs, and I've noticed, especially since taking the workshop, how much influence the staff and people caring for the patient has on their experience, and what a really, really big difference it can make. So when you are doing your workshops, what is it that you want people to understand and come away with? And what are some of the skills that they learn when they come?
I think it has to start with awareness first. And if you remember at the beginning, the first didactic portion introduces everyone to the concept of trauma. Like, what are we even talking about? What is psychological trauma? Not necessarily motor vehicle accident type of trauma. Although physical trauma and psychological trauma they often coexist. One might trigger the other, but it doesn't necessarily have to be there. So the workshop starts with a really solid introduction into that. It also introduces the ACE study to people. And I didn't learn about the adverse childhood experience study until I trained as a sexual assault counselor. And I kept saying to myself, how is it that this study came out in 1998 and I'm just hearing about it now in 2015-ish? It was one of the most important studies, and I think everyone needs to understand how childhood adversity impacts health, not just mental health, but physical health as well. We're all providers, and I think it allows us to see people differently. So I always make sure to introduce that. It's also an introduction to how trauma appears in obstetrics. Again, what you were just asking, not just the physical ways, but how, from a psychological perspective, what is meant by triggering when someone has trauma and comes to obstetrics, and those that are traumatized in obstetrics de novo. So that is a really important part of what I do, is making sure people understand that. The second part, which I have to say I think is my favorite, and Angela, you can comment on what you thought about the narrative exploration, which is all about perspective taking. I don't think that we're going to make significant change until we all learn how to see something from someone else's perspective. It's not easy to do, but I found that sharing these narratives that are handwritten by patients and given to me with the intent of sharing them with providers in the hopes of making change, it really does stimulate a lot of conversation. And we separate into groups so that there are mixed disciplines at each group reviewing these narratives. So it's not just perspective taking about the patient, it's perspective appreciation from around the table. So maybe as a nurse, you understand what it's like to be a social worker, seeing this from a different perspective, or the obstetrician or an anesthesiologist. So I think that is a key part of learning about trauma, is to see it from someone else's perspective, and how do we get there? And I keep thinking about different ways to maybe bring in patients in person to share some narratives as well. But that's a hard thing for them to do too, because telling their stories is akin to reliving the trauma. Other things that are important is to give individuals skills. It's one thing to talk about it and say, okay, I understand what trauma is. I can see it from somebody else's perspective, but Dr. Vogel, what do I need to do? That's what everyone asks me. I need skills. What do I say? How do I engage with this? So that is an important part of what I do with my teaching, is collecting as much data, as many research papers as I can find, and also put in some of my own clinical experience into what works when you're talking to individuals who absolutely do not trust you. Right? The key thing, number one, is how do you create trust? Maybe sometimes the easiest thing is to sit in a chair and listen and not talk. That could be key. And it's awkward for us as providers sometimes to just listen. But I do a whole session on what are the strategies? What do we need to do? Including for ourselves, what are some strategies to help keep us calm during crises? What can we do to ground ourselves so that when we engage with these patients that are challenging to us, we can remain calm and appreciate our own inherent traumas before we go in. So we teach that as well, and then have people go through simulated circumstances so that they can practice with those skills to hopefully cement them. And then the last part of it, which is absolutely crucial in any type of trauma work, is understanding how to take care of oneself. Because I really do think that we are a huge population of traumatized individuals that get no support or very little support for mental health. There's still so much stigma for any kind of provider to reach out to mental health. There are reasons why people don't want to have that in their charts, that they have mental or behavioral health issues. And I think it's important to talk about it. So it almost becomes at the end a little bit of a support group for us as providers to talk about what are our barriers and how can we go forward. So we end with some hope too, because we are making change.
Yeah, I have to say that attending your workshop definitely highlighted some of my own trauma around birth and having babies. I have 4 children. I started to notice how I interact with patients when those feelings are starting to come up. And I think that we talked a little bit about this before we had our interview about the importance of making sure that the healthcare providers are really supported and cared for. Because, if you don't understand your own perspective and your own trauma, you're going to have a really hard time connecting with other people. So what is your vision for that? Like, how do you feel and how do you think about what should happen with providers who are caring for this kind of population? Actually, all populations, because we can see trauma just about anywhere. It doesn't necessarily have to be just an OB, but what are your thoughts there?
Number one, I would love to see more hospital leadership personnel come to these workshops to truly understand what's happening, not just with our interactions with patients, but to really understand what's happening to the people that work for them. And to understand that if we are a traumatized population, we're not doing good work. We're not able to engage. Like you said, it's hard to truly offer that connection to patients. And in certain areas of medicine, it is essential that we do that. It's essential not just for the patient care, but it's essential for us to find satisfaction and meaning in our work. I think that's one of the biggest causes of burnout, is that we have walled off our emotional connection to patients. Even though we think that's protective, in the long run, it's been shown to be unproductive and lead to burnout and dissatisfaction. So I would love to see more leadership come. So one, they understand what is happening. We need more time. Every place I've been, the number one barrier to allowing for ourselves to get healthier is time, and then the right kind of support. And we're not talking about, hey, here's a gym membership, go do yoga, go do this. There's more to it. Providers need to have validation, and they need to have a space where they can talk about what has happened to them. And they need space to do it acutely as well. It's hard for me to even imagine being an obstetrician who just had an emergency cesarean surgery with a perinatal loss, unexpected, and then to have to turn around and walk right down the hall and do another procedure, deliver another baby, do another C-section without having a chance to talk to somebody, decompress, and express some emotions. I think it's really harmful. So we need to put some plans in place that allow for some backups, especially in environments like OB, where we have significant amounts of trauma and perinatal loss and acute crises. But I agree with you, it could happen in a lot of different areas in the hospitals. I'm doing some some more reading and investigating now into secondary preventive strategies. So let's say a trauma happens. Is there something we can do for providers? Like what we're thinking about doing with patients? Is there an intervention, EMDR? There's some work with playing the game Tetris. Within 6 hours of a unplanned cesarean birth, paper just came out that showed that that helped to decrease the symptoms of trauma 6 months down the road. What if we started to think of providers the same way we're thinking about patients? Let them go play Tetris for 15 minutes. I'm not sure, it sounds crazy, but we're not doing anything right now. I'm thinking about starting some support groups for providers. And it's just to talk about birth trauma because it doesn't exist. And I think it's needed. So those are some ideas that I have. Also opening up my clinic to some of my colleagues where it's not necessarily mental health. So that doesn't have to go on their record as seeing a mental health professional. Because I'm a licensed anesthesiologist, there are some benefits there. So maybe that would help also, and see if other places can do the same.
I think that's a great idea. My experience is that, whenever I have something that happens, I usually turn to my colleagues, and we all talk about stuff. But I've noticed that often that's not real helpful because people have their own biases and issues about how things should be handled. So, I've definitely had the experience where I was like, oh, this was terrible, this horrible thing that just happened. And somebody would be like, oh, I don't know what you're even worrying about it for. It's not that big of a deal. You know what I mean? And that's them. You know what I mean? That's them. They can't even begin to broach this. And I can recall too, really early on in my career, really kind of staying away from the emotional side of things. And I think that, what you're saying is really true in at least my own experience, again, because as an N of one in my pre-workshop, post-workshop, it really made a big difference in how I can relate to the patients. And it's not as scary or difficult or draining as I once thought that it would be. And as a matter of fact, it makes it real easy to kind of walk away from it because you're kind of processing it in the moment and having that exchange with a person, which I don't know, actually makes the day better, even when it's challenging.
Thank you for sharing that. That's wonderful to hear, because I do feel like when I give some of these skills to providers, that's what I'm hoping to do for them, is to help make their lives easier, not just allow the patient to have a better experience. But you use the words like it's not so draining or so difficult. And with my work, I feel the same way where I am now. And I work with traumatized individuals exclusively, and they all come with their own challenges for me in terms of how to communicate, how to connect with them. But I'm not drained. Some days are harder than others, but it is so meaningful. And I think a key to that too is when you understand where they're coming from. And I've said this before at some of the trainings, I want to shift how we see people and move from the fact that we think they're problematic to symptomatic. And maybe if you see them as symptomatic, like someone with a glucose of 35 who might be not paying attention to you, might be combative, might say things you don't want to hear. That could be the same as someone who's being triggered because they've had prior trauma and they're in an environment that's terrifying for them. Just like if somebody's glucose is 35, I think most people don't take that personally. They say, oh, their glucose is 35. Let's get them a bag of D5. Same thing with someone who's traumatized. If we can change how we see them to say, I get it. This is why they're behaving the way they are. This is the environment. It's a trigger. It's this. It's not about me. I don't need to take this personally. And I can understand it and move forward and maybe, like you say, even connect a little bit better. And it becomes a less toxic day for providers, I think. But I'm really appreciative that you shared that. I'm really happy to hear that.
I was actually really surprised at how that went when I went back to the OB floor. OB specifically, because I still do a mix of all different things. It really kind of surprised me in a really good way. And I think it's made a big difference in how I react to or how I interact with the patients that I'm taking care of. It seems to be able to de-escalate all the things by just sort of acknowledging that whole perspective. What are your thoughts moving forward? If anything could happen, kind of a thing, like what is it that you would hope for in doing this kind of work?
Oh, that's like my wish list, right? I would love to see support from every leader in every hospital, institution, primary care office, like not just obstetrics, but I would love to see there be support, not necessarily a mandate, but strong support both financially and even verbally, and just encouraging providers to get some training in this. That's number one. I would love to see it, some more funding go into research, because everyone loves to see the research to show that this is working. We have a project going on where I am now to see if a trauma-informed care clinic can decrease mental health symptoms postpartum, can minimize ER visits, can improve opiate control in terms of usage postpartum, things like that. We could do so much more work. So I'd love to see that going on. What's on the horizon for me right now, and I'm really excited, is that the same work I'm doing with the Pennsylvania PQC, which is how you received your training, I'm looking to expand that into other states. Right now, I've already been invited to go to Utah and do some there. I'm going to Louisiana to do some there. And there is some talk about Illinois. So this could expand to multiple states. Now, I'm obviously one person. So my next step is to build a train the trainer type of model, especially in Pennsylvania. And they'd like for me to start with that here. I think our state has done amazing work in not just with what I get to do in obstetrics with our PQC, that's the Perinatal Quality Collaborative, but we also have something called HEAL PA, and I co-chair the action team for physical and behavioral health. And our state, our governor, wants Pennsylvania to be a trauma-informed state. So we have these action teams in every aspect of society: education, law enforcement, health, mental health, which is all health. And that is incredible. So being able to do this work in Pennsylvania is wonderful. But like I said, I'd like to see that expand across the country. Could we put some of this training into more of I hate to say put it onto a video, something that could be accessible online, but it would definitely get to more individuals. But I do think in-person trainings, once every so often, once a year, once every 2 years, and then video trainings with it might be helpful. So that's my vision, is to keep going with it and keep developing new things, whatever's needed.
I mean, for me, the in-person training was fantastic. I think that by being in the room, it was much more difficult to get up and walk away, because there was definitely a point in time where I was like, oof, this is hard for me to sit through and listen to. And I know you kept saying you were wonderful. You kept saying over and over again, if you're feeling away, go ahead and take a walk. Don't worry about it, whatever. But, then there's that whole self-flagellating, I'm not going to get up and leave the thing that's hard. You know what I mean? I'm going to sit here through it, because if I had to watch that on a video, I probably would have got up and walked away, because it would have been hard. And I also feel like your whole staff, everyone who was there that day, was so incredibly supportive and understood the gravity of what it was that we were doing. It was healing in and of itself also. And it sort of gave me, again, N of one, the opportunity to say, oh, maybe this is something I need to start to think about and work with a little bit. And I like I said, it's probably one of the things in my 26-year career in nursing that has made the biggest impact in anything that I've done.
Angela, thank you for sharing that as a teacher. you can't ask for much more than to know that maybe what you've done has moved people, changed. And that's one of the reasons why I do believe in person is so much more meaningful. One, yeah, you don't have an opportunity to close your computer and walk away, but we have to learn to connect with each other. I know we do a lot online, and we had to do that through COVID, but there's so much that we're learning, and we're supporting each other in that environment. It is hard, like you said, but to hear about it with people that can help and support you in those moments too. Like, I'm trained to help if someone had a panic attack. I could help them in those moments. We collect a lot of data from all the trainings we do. And with the first round in Pennsylvania, about a third of people reported some level of triggering with that training. It's inevitable because like you said, it's hard stuff that we're talking about. And whether that's someone has trauma from their childhood, trauma from birth, trauma from work, a significant number of people come into that space for the workshop already having had trauma. And so you're right, it makes it hard. But it is almost like a giant support group as well as a learning environment. So I hope a lot of people felt the same way you did when they left, that maybe it was hard, but maybe it was their aha moment to open the doors for them to go and seek additional support or behavioral health therapy. I've had individuals come up to me after and say, I never realized this is why I am the way I am, and I'm going to go seek help now. So, whatever, there's so much that happens in that session. It is kind of amazing.
Yeah, it really is transformative. That's probably the best descriptor. Really is. Did you ever read Mark Epstein's The Trauma of Everyday Life?
I have not, but I will add that to my list.
It's a really good one. But he's a psychiatrist, and he says that everyone suffers from trauma. It's either pre-traumatic stress or post-traumatic stress, because we just do. You know what I mean? We carry things that we don't even know we carry. I want to be very mindful of your time. Thank you so much. I really appreciate the conversation that we had. Is there any last minute things that you want to add before we wrap up?
I would just say that I'm very hopeful. I went through a long phase. I mean, I've been doing this work for about a decade now, maybe a little bit longer. I just didn't know what it was initially that I was working on. But I do think, and this is also something I take away from every workshop that I do, is that I feel the energy of hope that is there. We're creative people, and we've just experienced such trauma, but also just this weight that's been put on us through COVID, which is a communal trauma that we've all endured as providers. But I think we're exhausted, many of us. And just to see the ideas circulating about what can we do from an individual level? What can we do on our units? What can we do if you are in a leadership position? What change can you make? If you have a platform and you do a podcast, what can you do with that power? But it's really uplifting and hopeful, because I see so many wheels turning in that space of, I can't wait to get out of here and start making change. And that to me it's exciting. It is hopeful. And at this point, we're seeing such I would say a blast is the best word I have for it, of so much research, so many papers coming out, so much interest in histories of adversity and trauma and health. And where's that going to take us? So I think our pendulum had swung so far the other direction, but it is now getting momentum and moving back to where we need it to be. And I'm hopeful. I just think that we're all going to do some great things. We just all needed that permission, I think, to say, this is not right. This is not good right now. And we can all work together to make it better.
Hello, Dawn.
Hi, Angela.
How are you?
I'm doing great. How are you?
Great.
Awesome.
So I did this interview with Tracey Vogel.
Yeah.
Dr. Tracey Vogel, who is doing amazing, amazing work in obstetrics and with trauma-informed care,
Yeah.
which is really incredible, really admirable. I think it's so important. And it's important for all patients, not just for obstetric patients. But, this is a population, I think, where we see it a lot more because, there's so much that goes into obstetrics. But I think that I really wanted to do this interview. I did her training course,
Mm-hmm.
which was really, really incredibly powerful. I highly recommend it for anyone who has an opportunity to do it,
Right.
to listen to the patient stories
Yeah.
and listen to people talk about the experiences they had and the difference that it made when people were able to recognize that they weren't okay with what was going on and were able to help them through it.
Mm-hmm.
So I think that this, has the potential to really impact how we take care of people.
Right.
And then, also leading into how we take care of ourselves as healthcare workers.
Oh, sure. Yeah. There's a lot that goes into all of those things. I listened to her interview and I actually, after the fact, went on the Empowerment Equation website, which I thought was like really well put out, but just the information that she put forth. And I know you said like her focus is obstetrics, and it's interesting to think about it because in obstetric world, it's just supposed to be so pretty, and they're bringing a new baby in the world, and like how cute is the baby and everything, and we all go through that, but we forget about the experience of the mom. And for years the mom remembers, like, the things that happened to them. I mean, you and I had a conversation, and our kids are, I mean, I have the youngest of our 7 and he's 17, but you remember the experiences that you had, and they weren't all like rainbows and unicorns at the time, but they definitely shape the way even I, as a nurse anesthetist, look at healthcare in general, so our experiences as healthcare providers are shaped by our experiences as patients in a healthcare system. So I think she's
Yeah.
great things that it's, if we embrace it and we can empower patients to be more vocal about, like you said, not being okay with what's going on.
Yeah. And I think too, like training healthcare providers to be aware and cognizant of that
Yeah,
instead of just going about their business as if, and it's challenging, right? Because this is our job. This is what
yeah,
we do every day. You know what I
right.
mean? We're essentially no different from the cashier at Wawa, just showing up and doing the thing that we do every single day that brings us our paycheck. And yet, we're meeting people, it's important to recognize that we're meeting people in a really, really vulnerable position.
Agreed.
And, it's not a typical day for them.
Right. Yeah, you're right.
Yeah. So, and they're bringing with them everything, all of their experiences that have happened before. So just being aware of that, I think, is a really great start. But her training is incredible. And I hope that, she has the opportunity to grow it, and then everyone has an opportunity to see it because it's really, really impactful. It's made a profound difference in how I practice.
Oh, yeah. I think that any time that we as healthcare providers can provide education on how to be better providers of healthcare, you can't go wrong with that. And to your point, she has a consumer base, and it's imperative for us as anesthesia providers to reach out to our base of anesthesia providers so that they too can see the benefits of the training that she does provide. So I mean, she's on to something fantastic in a way that's really going to be helpful for healthcare overall, like really globally, if you think about it.
Amplify Nursing is hosted by Dr. Angela Rosa DiDonato and Marian Leary, and produced by the University of Pennsylvania School of Nursing, with special thanks to Jonathan Zhu for his assistance. Music for the podcast was created by Harper Leary. The podcast is made possible by the Krista and Rich Pinola Fund for Innovation in Nursing.
Follow us on Twitter at Penn Nursing. Until next time, keep pushing over, under, around, and through. We want to thank you for listening to the Amplify Nursing podcast and remind you to subscribe to the podcast on iTunes, Google Play, Spotify, iHeartRadio, or wherever you enjoy your podcast listening. And if you can do us a solid, please rate and review us as well. It will go a long way in amplifying our episodes.